That is the question that has been asked. So structures visualized, airway structures that can be visualized are ultrasound tongue. You can visualize the tongue, epiglottis, hyoid bone, larynx, vocal cords, trichothyroid membrane, trichoid cartilage, thyroid cartilage, trachea, and esophagus. All these structures are usually visualized using ultrasound. And there are majorly two approaches. One is called the transcutaneous approach, which can be used for regularly used also in practice. Examination upper airway from the floor of the mouth to the suprasternal notch. This is the area through which you can do the examination. And even paratracheal structures using either a linear or curved transducer can be done. And the planes are actually four. You combine the oblique in the one of the transverse or any other thing. So they sometimes say there are four planes: sagittal, parasagittal, transverse, or oblique planes. And majority of the times, oblique will be combined with either a transverse or sagittal. And the other approach is transoral or sublingual. So there are small probes which can be introduced through the mouth also. So excellent probe tissue contact which can be achieved by this approach without inciting the gag reflex, thereby producing clear images from the points in favor of this technique. But we do not use this in practice. And whereas the uneasiness of probes underneath one's tongue, the inability to use it in children or uncooperative patients, or inability to visualize the trachea, requirement of a small footprint probe and steeper learning curve, all these things are not in favor of this approach. So commonly we use the transcutaneous approach. But exam from theory point of view, you have to write about the both the approaches. And what are the major clinical applications? Identification and prediction of difficult airway. Identification of trichothyroid membrane, very useful in cases of difficult airway anatomy, emergency settings, doing retrograde intubation, for doing trichothyroidectomy or percutaneous tracheostomy. For all this, we have to identify the trichothyroid membrane. Periodic the prediction of appropriate endotracheal tube also can be done by measuring the subglottic area, which is the smallest the upper airway diameter. And the measurement of subglottic airway diameter enables determination of the appropriate size of endotracheal tube and the possibility of post-intubation laryngeal stenosis also. The determination of size of W-lumen tube, it also can be done. This outer tracheal width is measured at a level just above the sternoclavicular joint. This measurement is used to determine the appropriate size of the W-lumen tube. So previously, how were we calculating the size of the W-lumen tube? Savitra, any idea? What is Perry's formula? Height in centimeters divided by 10 plus 12. That is the formula that you have to use for calculating the outer diameter size and inner diameter size of the W-lumen tube. Whereas with the USG, you can straight away measure this tracheal width and then select the W-lumen tube. And this has found to be good correlation with a widely accepted CT scan based evaluation also. And confirmation of the endotracheal intubation in patients with cardiopulmonary arrest, especially who are not breathing, the pulmonary embolism or severe bronchospasm or technical problems with capnography, this will be useful to confirm tracheal intubation. So whenever the alpinography, which is the gold standard, cannot be used for confirmation of VT tube, ultrasound gives a fairly helpful hand. And confirmation of correct ET tube depth, especially in pediatric population and in pregnant women. So endobronchial intubation is very, very common if you are very enthusiastic in passing the tube into the trachea. So tracheal rapid ultrasound saline test, TRUST, involves inflating the ET tube cup using saline instead of air to overcome the problem of non-visualization of the air-filled ET tube. and it can determine correct placement of ET tube when saline filled ET tube is visualized with the ultrasound probe in transverse orientation at the level of the sternal notch. So this is one of the things, TRUST, tracheal rapid ultrasound saline test. It's useful for assessing the depth of the ventricular tube and detecting endobronchial intubation. As she rightly said, you can see the lung movement, lung sliding sign on the ventilated side and no lung sliding on the unventilated side. So you have to see for the lung movement for that. The other use is dilatation of percutaneous dilatation tracheostomy. So you can avoid false passages and you can avoid injury to other structures. And the ability to measure the distance of the skin to trachea, especially in obese patients, it will be very, very useful. And real-time ultrasound guided tracheostomy is possible and has been proven to have relatively lesser complication compared to the traditional landmark-based or bronchoscopy guided. And the first pass puncture rate is very much more and accuracy is very correct. And prediction of post-extubation stridor, detection of laryngeal mask airway position. This is also another use. And assessment of vocal cords, determination of recurrent laryngeal palsy, and useful in patients who are uncooperative for laryngoscopy or fiber optic bronchoscopy. And you can detect tracheal stenosis in patients who have been on tracheostomy or long-term intubation. And determination of tracheal wall thickening. This thickness occurs in conditions of infection in mucosal edema, sarcoidosis, and other diseases. Tracheal invasion due to thyroid cancer that also can be detected. Identification of intrathoracic extent of goiter. This is another important application so that you can know if there is a compression of the trachea behind the sternum. And diagnosing epiglottitis. Diagnosis is special importance in oncology patients who develop epiglottitis after radiotherapy to head and neck, or prevention of airway complication and prediction of difficulty airway, and diagnosis of obstructive sleep apnea. This is another newer use that has been added. So submental ultrasound is used for this purpose. Parameters to diagnose are tongue base thickness, distance between two lingual arteries, diameter of the retropalatal space, lateral pharyngeal wall thickness. If all these things are measured, you can find out whether the patient will have obstructive sleep apnea or not. And ultrasound guided upper airway anesthesia to facilitate awake intubation. And limitations. So these are all the applications and the advantages of using ultrasound. The limitations are operator of ultrasound machine is required to have a sound knowledge of sonography. So it is the beginner may have find it difficult to identify the structures. And image acquisition is dependent on the equipment and the operator. So you must have a good ultrasound machine also. And interpretation is operator dependent. So what I see as a hyoid bone, somebody else may be seeing it as a part of thyroid cartilage. So it is operator dependent. It takes time to master the technique. So these are the limitations of that. So with that, I think we stop that.